Hi guys, welcome back. The next topic we're studying is autoimmune hepatitis, and this condition in pathology books is described as total of three varieties, type 1, 2 and 3. But in the latest edition of Harrison, it's only two varieties. So we are going to restrict our discussion to what's given in Harrison, that's type 1 and type 2 autoimmune hepatitis. Now the older term that is used to describe this condition formerly was leukoid hepatitis, and you will realize the reason for this because in the later part of the discussion I'll be telling you that type 1 autoimmune hepatitis will be having anti-nuclear antibody positive, which is why this term came up. An alternative term again being discussed is called as plasma cell hepatitis. Now the reason why I've described these terms is for those integrated kind of questions where these pathology terms may be present. As well as the 6-month mortality rate for this condition is concerned, if the condition is untreated, though it is amenable to treatment with steroids and azathioprine, but if it is undiagnosed, unrecognized, then the mortality rate can be a huge 40%. Contrast that with hepatitis B. In hepatitis B, I've told you 90% cases will show a spontaneous recovery. They don't even need to come to the doctor for a consultation. The jaundice will disappear on its own, body will recover. In 10% cases of hepatitis B, they will get converted into chronic hepatitis B. And even if somebody is having chronic hepatitis B, treatment is available, no, with help of antiviral drugs, and person will again recover. So chances of dying with hepatitis B is very, very unlikely. But with autoimmune hepatitis, because it goes undiagnosed, therefore mortality rate is up to 40%. And therefore the question arises, why is the person having autoimmune hepatitis? Well, the exact cause is not known. But what we know is that there is a loss of tolerance. Like traditionally in our body, it can differentiate between self and non-self. Non-self organs are rejected. But in this particular case, it has been shown in clinical studies that there is a loss of immunological tolerance to self-liver antigens. And what I mean by self-liver antigen is that the antibodies which will develop in this condition will attack the cytochrome P450 system in the liver. They will attack the blood vessels supplying the hepatocytes. If the blood supply of the hepatocytes is affected, the cells are going to start dying. And therefore in histopathology, you will read about rosette formation. Rosette formation again is a very peculiar term for liver. I mean, you read about rosette and pseudo-rosettes in pathology, that's okay. But every time you read about rosette formation in liver, from a histopathology perspective, you must think in terms of autoimmune hepatitis. As far as the triggers for this condition are concerned, it could be hepatitis A, B or C. A large number of these cases will initially be misdiagnosed as having chronic viral hepatitis, but the viral markers will turn out to be negative. Like for hepatitis B, you know that you need surface antigen positivity. You need antibody to the core antigen IgG class to be present. But in this case, those markers will turn out to be negative. He might have had a hepatitis from any one of these viruses maybe 20 years ago. Now he started having features of autoimmune hepatitis. So possibly, I mean, A, B, C, D, please don't be under impression that these are causes. These are triggers. There's a difference between a trigger and a cause, because trigger means that manifestations will develop that post recovery. He has suffered from infection with this virus and then his body has lost the ability to recognize self and non-self. So these infections he has recovered, but later on, the liver is getting damaged. We thought it is due to the virus, but virus infection had already cleared. For diagnosis of this condition, we have to prove that there is no viral insult to the liver. It might have occurred in the past, but currently there is no viral insult. We need to rule out viral causes. We need to rule out drug-related causes. We need to rule out genetic causes like Wilson hemochromatosis, and that is when we think in terms of autoimmune hepatitis. So this is a diagnosis of exclusion. This can be associated with autoimmune disorders like inflammatory bowel disease, like ulcerative colitis. Then can be associated with celiac sprue. Yes, the same celiac sprue where we get anti-TTG antibody, tissue transglutaminase antibody. It can be associated with MPGN, membranoproliferative glomerulonephritis. So a couple of these associations have to be remembered from the exam perspective as well. In fact, sometimes we also see autoimmune hepatitis in association with Hashimoto. That is where we get anti-TPU antibodies. Let's just quickly do a revision. No need to note it down. Inflammatory bowel disease, you know from GI. So I'm just saying it verbally. I'm not writing it. I think I've discussed that in GI. That with Crohn's we have ASCA, no? Anti-Saccharomyces cerevisiae antibody. With ulcerative colitis, we have P-ANCA. Then celiac flu, I've discussed it is anti-TTG, tissue transglutaminase antibody. So we have specific antibodies for each one of them. For Hashimoto, it is anti-TPO antibody. And then a couple of these patients can be having autoimmune hepatitis as well. And now let's look at the two varieties of autoimmune hepatitis, that is type 1 and type 2. For type 1 autoimmune hepatitis, it will mostly be a young female. As far as the country of origin is concerned, this could be a Canadian or an American patient. Whereas when it comes to type 2, the person will be relatively more young, and this would mostly be a European patient who would be residing in area around the Mediterranean Sea. Countries like Turkey, countries like Ukraine, all of these are like based around the Mediterranean Sea. So that area where we usually get type 2 autoimmune hepatitis. Now the diagnosis is based not only on the basis of age group, I mean younger patient, or I can say this would be a child. Type 2 hepatitis is still more. By young I meant even younger than type 2. This is a young female versus a child that I'm describing. And type 1 autoimmune hepatitis will be having alphabet A coming up again and again. Anti-nuclear antibody. Just remember at the moment A1. That is type 1 comes first and A also comes. One is associated with anti-nuclear antibody. Another antibody which is seen here is called as anti-SMA, that is smooth muscle antibody, and this anti-smooth muscle antibody will be acting against actin. Now when I'm describing this, the query of most people is that in the liver, where is there actin present? So you see in the liver, obviously there are hepatocytes, but there are blood vessels also. And every blood vessel is going to be having connective tissue now. And in the connective tissue, what is present? Actin. So this disease will be affecting the blood supply of the hepatocytes, which will cause the hepatocytes to ultimately die. That is anti-smooth muscle antibody. Asthma may be written ASMA. That could be a term that could be written in some MCQs or some books. Or you might describe it as whole anti-smooth muscle antibody, which is directed against actin. Another antibody which is present here is again having a alphabet A present, that is SLA, anti-SLA antibody, that is anti-soluble liver antigen antibody. And at this juncture, all I want to do is draw your attention to this alphabet A again, anti-nuclear antibody, SMA antibody, soluble liver antigen antibody. That is why I was requesting you to remember A1. Now for the right hand side, what I want you to remember would be a term that would be L2, because on type 2 there would be a couple of antibodies beginning with alphabet L, and type 2 autoimmune hepatitis, the Mediterranean variety, would be anti-nuclear antibody negative. The antibodies which are present here would be having starting with alphabet L. The first one is anti-liver kidney microsomal antibody, anti-LKM1 antibody. Now, as far as this anti-LKM1 antibody is concerned, liver kidney microsomal, this antibody is directed against the cytochrome P450 system. You are aware that in the liver, liver is responsible for deconjugation with relation to multiple drugs. That's where the cytochrome P450 plays a role with respect to metabolism of drugs, and that cytochrome P450 is being attacked by this antibody called as anti-LKM1. The second antibody which is present here is again having starting with alphabet L, that would be liver cytosol 1. So one, you need to get hang of this terminology that I have described. That would be A1L2. For A1, that is type 1 autoimmune hepatitis, it is anti-nuclear antibody, smooth muscle antibody, soluble liver antigen. And now here it is alphabet L that is coming up, LKM1, and then liver cytosol 1 antibody. So you just need to get a hang of these terminologies that I mentioned, or the antibodies that are described, and you would be sorted for type 1 and type 2 autoimmune hepatitis. And before I go into the clinical details for what's going to actually happen to the patient, I would also like to use this opportunity to mention regarding a miscellaneous fact. That is, they have put up questions in the exam, one-liner questions in NEET PG and FMG, where I've talked about anti-LKM2 antibody. This anti-LKM1 antibody is the one that's related to type 2 autoimmune hepatitis, but anti-LKM2 antibody per se is related to drug-induced. This is related to drug-induced hepatitis. Then anti-LKM1 antibody is also seen with respect to hepatitis C. And the importance of knowing this information is that this antibody that I'm telling you at the moment can cause a false positive enzyme immunoassay for hepatitis C as well. I'll repeat that once again. Anti-LKM1 antibody that's seen in type 2 autoimmune hepatitis can contribute to false positive reports of hepatitis C as well. So you just need to remember this association, that anti-LKM antibody is related to hepatitis C, anti-LKM2 antibody is related to drug-induced hepatitis, and then anti-LKM3 antibody is related to hepatitis D. These are like couple of associations which should be remembered for antibodies and the corresponding, viral associations or the drug-induced associations. First, your job would be here to get into focus A1, L2. And once you get that A1, L2 right, with that alphabet A coming more on the left hand side versus alphabet L on the right hand side, then you need to remember you have more work to do with respect to getting these antibodies right. And what I can say at this juncture is that if you get these infrastructure with respect to this antibody orientation that I've given you imprinted into your brain in your own handwriting, though you have the luxury of printed notes, if you write it down by yourself on a slip-on chart and keep it in front of you for, let me say, a day or so, this would become much more the solving these. And because these are going to be fact-based questions which would become easier if you're going to make it or note it down in your own handwriting. Another aspect which I would now like you to remember is X ANCA. When I write that, the query is usually we have read about C ANCA and P ANCA, because C ANCA is what you read with Wegener's granulomatosis, and now that word Wegener's granulomatosis is not used, so we use granulomatosis with polyangiitis. And then you read about P ANCA also, that P ANCA antibody is associated with microscopic polyangiitis and Churg-Strauss syndrome. So, C ANCA, P ANCA is routine bread and butter kind of MCQs, but I am teaching you X ANCA. This X ANCA is also written as atypical and was again a question in, I think this was any set exam, so slightly difficult. This is actually a atypical P ANCA. I told you P ANCA we read with microscopic polyangiitis or Churg-Strauss. The MCQ said atypical P ANCA, or in some MCQs has been written as X ANCA, is again related to autoimmune hepatitis type 1. So you just need to have, a little bit of more information added here. I've already added that A1 data for anti-nuclear smooth muscle antibody and soluble liver antigen. Now added one more, that is X ANCA is related to, answer is again autoimmune hepatitis type 1. Let's now focus on the clinical features. A large number of cases may initially be symptomatic. The disease, like any autoimmune disorder, may be having a waxing and a waning course. So sometimes there might be no symptoms present in the case, and only on a medical checkup, because the SGPT of the person was grossly elevated initially and serum bilirubin was normal, that is when this patient came to medical attention. Though this person is asymptomatic, he says, I get tired very soon. So there would be fatigue that could be described. There could be anorexia. There could be acne. And because I'm describing a female patient, there could even be amenorrhea. All the features that are written at the moment are very, very non-specific, and I do not have any inkling of the fact that this person is having a liver damage. I will come to know that there is a liver damage only when this person will start developing jaundice, and I will think that this jaundice is because of an infective cause. But then this person is telling me that even last year I had developed jaundice which went away on its own after a couple of days or a couple of weeks. So we will be getting a history of a waxing and a waning course with respect to development of icterus. Now, traditionally, icterus can be present with even conditions like Gilbert syndrome, where with Gilbert's disease, we get jaundice that can come and go, especially with respect to excessive physical exercise, with respect to drug intake. Similar kind of possibility is what I'm suspecting here, because jaundice came and went away. So even at that point of time, I thought maybe it could be a case of Gilbert's disease. But then some additional features is what I'm encountering in a question that could be in the form of maybe dry eyes and dry mouth, that is sicca, because see, this is autoimmune condition, so I have to tell you some autoimmune associations present here. So subsequently you will realize that okay, you are not dealing with a case of Gilbert's disease, because Gilbert can also be having a jaundice that might be waxing and waning, especially with excessive strenuous exercise, or if a person would be taking some drugs, some health supplements, that is when Gilbert can contribute to jaundice. Like in a female, if she's taking OCP, it can cause a jaundice. But then these additional manifestations that I'm saying, like Sicca syndrome manifestation, erythema nodosum, that would be purplish lesions on the skin of a person, would bring to your attention that okay, there could be an autoimmune etiology associated along with development of jaundice. If the disease goes undiagnosed, which is a high probability in large number of cases, because I said majority of cases are misdiagnosed as chronic viral hepatitis. We think it's due to infective etiology, it is autoimmune etiology. These patients will go into cirrhosis, and if they go into cirrhosis, then manifestations like ascites or features of portal hypertension like bleeding esophageal varices, caput medusae, that would be dilated veins around the umbilicus of a patient, can be present. A large number of cases can go undetected. That is why the mortality rate was fairly high, going up to 40% for this condition. And adding insult to the injury, rubbing salt into the wounds, this condition can contribute to development of liver cancer as well. Though one of the leading causes of hepatocellular carcinoma is hepatitis B for Bombay, followed by hepatitis C. But hepatocellular carcinoma, remember that MCQ statement, hepatocellular carcinoma risk is increased with autoimmune hepatitis, and this could be associated with like Zika syndrome, erythema nodosum. Some autoimmune manifestations could be present or could be coexisting in a person with inflammatory bowel disease, or could be coexisting in a patient with Hashimoto's thyroiditis. We'll now focus on the workup for these persons. So when I'm gonna do LFT, I will notice that if he has come to me at that phase of time when serum bilirubin is elevated, then most of the time unconjugated bilirubin would be elevated. Liver enzymes like SGPT, SGOT can be elevated. Mainly SGPT is elevated, and serum alkaline phosphatase can either be normal or slightly increased. Along with this, when you check out the serum albumin values, the serum albumin is lesser because damage to liver has started, and you will notice that the value of gamma globulins in these patients will be markedly high. The reason for increase of gamma globulin is because gamma globulin is catabolized by the liver, and if the liver is damaged, then catabolism will not occur, so gamma globulin is increased. Some of these patients might even be RA factor positive as well, so that's the autoimmune association that I'm trying to say. And initially I will still be under impression that this could be a viral cause of damage to the liver, because that's the usual thing that we see. So when I'm going to do a viral serology, the viral infection panel will turn out to be negative. Due to damage to liver, any liver damage will cause prolongation of prothrombin time or international normalized ratio. But at the moment, because viral etiology was negative, there was no family history in the person also. There was no family history of any genetic disease, and therefore I decided to do an autoimmune panel, and anti-nuclear antibody is turning out to be positive. Though anti-nuclear antibody can be negative with respect to type 2 autoimmune hepatitis, so let's look at the test that we'll be writing, like anti-smooth muscle antibody, anti-soluble liver antigen antibody, anti-LKM1. So I've just written those tests once again. That is, the autoimmune liver panel will turn out to be positive. The next test that would be done is the main test for diagnosis of this condition, that is liver biopsy. And the keywords, that is the main majority of questions he will himself. He does not expect you at an MBBS level to diagnose autoimmune hepatitis if hepatologists are not able to diagnose and mortality rate is 40%, then he will not expect you to clinically identify this on the basis of the reports that are given. He will himself give you liver biopsy finding, and if you read this word interface hepatitis and rosette formation, I mean, every time you read these two terminologies, that is interface hepatitis and rosette formation, the reason for this rosette formation is because of the regenerating hepatocytes, and the disease can affect even the blood vessels affecting the liver. For the diagnosis of this condition, I can say that diagnosis is of exclusion. I mean, how do you identify that it is autoimmune hepatitis? You have to exclude certain etiologies. You have to exclude viral etiology. They might have had a remote infection with hepatitis B or hepatitis C earlier. You have to rule out association with drugs. You have to rule out association with alcohol. That is one of the leading causes of damage to the liver. So viral, drug, alcohol, and then genetic causes have to be ruled out. That is the first thing he says, rule out. Just try to remember this with me, VDAG, that is viral, drug, alcohol, and genetic causes. And then you have to include, I mean, diagnosis of autoimmune hepatitis is based on exclusion of 4 important causes of damage to the liver. And then you have to include 2 things. One would be liver biopsy findings, which I have already explained to you. That would be regenerating hepatocytes contributing to rosette with interface hepatitis, and antibody panel as well. So the combination of these facts that I've written, that would be liver biopsy report, autoimmune antibody panel present, and ruling out viral, drug, and genetic causes. That is how autoimmune hepatitis is diagnosed. It is a diagnosis of exclusion. As far as the treatment is concerned, all you need to remember is we will give steroids, and because on continuous administration of steroids, they can be Cushing syndrome. So we would be happy to put the patient on the lowest possible dose of steroids, and along with that, we'll be using steroid sparing agents also like azathioprine. From the exam perspective, mainly for this topic, what you need to remember is this table that I've explained, including some tidbits were carried over to the next page as well. So I'm just jotting it down once again. X-ANCA association, because traditionally we read about P-ANCA and C-ANCA with respect to GPA, and microscopic polyangiitis. So this was a short topic with respect to the liver, but then because of the wealth of antibodies there, that's why the examiner is interested in picking up that topic, which we tend to read lesser. But you guys are smart. I've already told you that, I mean, in every topic, guys, what I try to do is focus on those slides which are the key aspects for the exam. And if you just make a note of them in your own handwriting every time I prompt you, you would be on your way to success and glory. So keep hammering and you'll do great in your careers.